Good morning, ladies and gentlemen, and good evening to Professor Masood Ahmed. Welcome you all to this Friday ECO 2020. This is the ECO Dhaka EU workshop organized by International Society of Cardiovascular Ultrasound Bangladesh chapter. This is the 15th day of this Friday ECO, and we'll today meet an expert in the field of echocardiography and non-invasive cardiology. He is Professor Masood Ahmed, and this session will be chaired by Professor Abdullah Shafi Majumder, who is the president of ISCU Bangladesh chapter. And we have got two panel experts in our panel, Professor Afzalur Rahman, who is the ex-director of NICVD, and Professor Wadud Chowdhury, who is the head of the department and professor of cardiology, Dhaka Medical College Hospital. We have got a number of other experts in our panelists, including Professor Moinuddin Ahmed, Professor ABM Abdul Salam, Dr. Ajay Dotto, Dr. Naharuma Chowdhury, Dr. Govindopal, and all others. May I request Professor Abdullah Shafi Majumder sir to say a few words about this session.
Yes, good morning and good evening. I welcome Professor Masood Ahmed, and it is our honor to have him to present his paper in this gathering. And I have met him on several occasions in the last few years, and I never thought that one day he might be linked to our program, but the COVID pandemic has given us that opportunity. So he is very much conversant with the point of care echocardiography in many different international meetings, and I was very much amazed in his presentation. So this time I offered to give a presentations in this webinar, and he agreed. So we feel very privileged and honored to have him in today's webinar. And you, Professor Masood Ahmed, you know that we have got the Bangladesh chapter in 2007 when Professor Ensinanda visited Dhaka for the first time, and we formed this chapter. And since then, we have been working for the development and the dissemination of knowledge on the echocardiography in different parts of on the national levels on different parts of the country. We have arranged different meetings. We have got the eco courses, regular eco courses organized by the ISCU Bangladesh chapters. And for the last 3 months, we are having this Friday eco. So all the important faculty of the country who are committed to the echocardiography have joined, including Professor Sajol Banerjee, Professor Tuhin Haq, Professor Khalid Mohsin, Professor Mohammad Shahabuddin, Professor ABM Abdul Salam. They are all the very important persons in the field of cardiology and the pediatric cardiology and the echocardiography in our country. All have joined today. So we think that you will be happy to have your presentations in front of this August gathering. So once again, I welcome Professor Masood Ahmed to this Bangladeshi program, and I also thank our faculty to join with this program and the fellows. This program is meant mainly for the younger cardiologists and the fellows who will have in the learning phase of the echocardiography. I hope this presentation will stimulate us, as point of care echocardiography is not that much familiar among our practicing echocardiographer or cardiologist. Though the term has been theoretically known to many of us, but we are not practicing it very much. I think your lectures by Professor Masood Ahmed will open the doors of our thinking to start this point of care echocardiography in our practice. With these words, and again, my thanks and gratitude to Professor Masood Ahmed to respond to my request. Thank you very much.
Thank you, sir. Thank you, Professor Majumder, sir. Ladies and gentlemen, point of care echocardiography is very much important in this era of COVID. Even in the pre-COVID era or along with the COVID, in the emergency room, in the ICU, CCU, where the hemodynamics is very much important. And in all other, in the emergency room with chest pain and respiratory distress evaluation, point of care echocardiography is very much important. Professor Masood Ahmed is going to tell us about
Professor
point of
Dr.
care.
Firoze,
Sir.
Can you make Professor Wadud, our panelist, to
Yes,
have some words before you
yes,
start?
I will tell that, sir. I will give him the opportunity. Sir, Professor Masood Ahmed is the Professor of Medicine and holds the Edward D. and Sally M. Futch Endowed Professorship in Cardiology. He is also the Director of Echocardiography Laboratory, and Dr. Ahmed is an inaugural member in the Academy of Master Clinicians at University of Texas Medical Branch. Dr. Ahmed research interest is in the field of non-invasive cardiovascular imaging, and he has expertise in 3D echocardiography. He is a board member of the American Society of Echocardiography Houston branch. He is also a member of the Scientific Committee of American Society of Echocardiography. And Dr. Masood Ahmed received his medical degree from Kashmir Medical College in Kashmir, India. He completed his residency in internal medicine in Euclid General Hospital in Cleveland, Ohio, and at Long Island Jewish and Queens Hospital Center in New York. Dr. Ahmed completed his fellowship in cardiology at Southwestern Medical School in Dallas, Texas, and he has taught a good number of fellows and cardiologists on the field of echocardiography. Previously, he was also associate professor of medicine at the University of Missouri Medical Center and served as director of non-invasive laboratories and chief of the cardiology section at the Henry S. Truman VA Hospital in Columbia, Missouri. Before going to presentation, may I request Professor Abdullah Chowdhury, who is one of the experts in the panels, to say a brief comment on this.
Assalamu alaikum, and good morning to everyone, and also to good evening to Professor Masood. Well, in this COVID era, it seems that every cloud has a silver lining. It becomes true, because only this situation has made this possible, that a world-renowned expert like Professor Masood, we are going to listen to him, his expertise on point of care echo. And yesterday I was giving a lecture in somewhere, and I was saying this point of care because this COVID has made us realize that our approach to many emergency situations depends upon largely on safety factor, both on the patient's part, both on the physician's part, the healthcare personnel. They should be taking care of that. And to realize that you have to have a sufficient knowledge and expertise to accumulate relevant information very quickly, very expeditiously, but very safely. Point of care echocardiography is teaching us how to do that. And I do think that will give us time how to make ourselves acquainted with this new approach. Thank you, Professor Masood.
Thank you, sir. Thank you. Now, may I request Professor Masood Ahmed, sir, to share his screen and deliver his lecture. Professor Masood Ahmed, sir, please.
Nice scene.
Let me go back here. That's my presentation, point of care echo. And the question is the stethoscope's 200-year reign over. Before I start, let me thank Dr. Majumder, Drs. Firoze, Islam, Rahman, and Dr. Chowdhury. I may be missing some of the names, but again, my greetings to all of the participants, and thank you for inviting me. And I'll take you through this topic, and at the end, we will have a little discussion. So I've posed a question here, is the stethoscope's 200-year reign over? We'll see where it stands now. I want to show you where I am. This is Galveston Island. It's an island south of Houston, and it's connected by a causeway with the mainland. It's a long causeway, I think maybe a couple of miles. And it's a beautiful island in the Gulf of Mexico. And our medical school is located on the east end of the island over here. So this is the town. You can see a boulevard there with some of the jetties out here, piers, a hotel. So it's a very nice resort, Sunset in Galveston. And this is a view of our complex, medical complex, about 70 buildings altogether. And this is a building that started the whole medical school. This is about 130 years old. It's the oldest school in Texas and one of the oldest south of Mississippi. And we favorably call this building Old Red. It's made out of red sandstone. We don't have any active working areas in this building. It's just mostly for visitors. There's a coffee shop there. But if you happen to come here, this would be a nice place to visit. And this is our hospital. It's like, you know, the new modern glass buildings. It has a very nice view of the water, ocean. And patients tell us they really enjoy staying here. Of course, they don't want to be here, but whenever they're here, admitted, they like the place. So getting to our topic, point of care echocardiography, we're going to approach it in 4 different areas. What is the accuracy of a cardiovascular physical examination? You know, we as cardiologists are very proud of being skilled in diagnosing different ailments from just the bedside physical examination. And how good is it? And you know, auscultation is an important part of the whole thing. Shown here is Lennox, a French physician, a couple hundred years back. And at that time, the physicians would listen to the chest directly. They would put their ear to the chest and listen to lungs and heart. This was not very hygienic. You can imagine at that time there were a lot of epidemics and things like lice and all kinds of things. And also not very modest for ladies. So Lennox happened to be watching a couple of kids playing with a little pin. They were scratching on one side of the log of wood, and somebody else was listening on the other side, and he was impressed by the transmission of the sound. So he got this inspiration and idea. He rolled up a piece of paper and made it into a tube and used that for listening heart sounds and breath sounds. And this tube gradually transformed into a wooden tube. So you can see Lennox holding this tube in his hand over here. This is the early version of stethoscope. And here he's listening to a young kid with his mother in front of him. And that was the early stethoscope back a couple hundred years ago, which then evolved into, this is my stethoscope now, the modern stethoscope with all kinds of different designs and basically just for transmission of sounds. And we still use stethoscope. I mean, not just cardiologists, but all physicians use stethoscopes. And in fact, it's a symbol of being a physician and an icon for physicians to carry around. And it has played a very important role in our diagnosis and management of patients over the last couple of centuries. Now, how good is it? How accurate is our cardiovascular physical examination? There are many studies out there about this, but I'll just show you a couple of studies. This was a paper published in JAMA back in '97 about a study for assessment of cardiac auscultatory skills in trainees. It was a multi-center cross-sectional comparison of 453 physicians in training and 88 medical students. All of these participants were asked to listen to 12 cardiac events directly recorded from patients, and then they were scored as the percentage of participants for the year and type of training and for correct identification of each event. And here's the data. This is an old publication. So we're looking at bar graphs here in 4 panels. The upper 2 panels show the accuracy percentage of either murmurs or heart sounds accurately picked up, diagnosed by either internal medicine residents in open bars, family practice residents in stippled bars, and medical students in black bars. So they listen to murmurs, for example, for mitral regurgitation, aortic stenosis, and combination of aortic stenosis and aortic insufficiency by itself, mitral stenosis, and patent ductus arteriosus. They also listen to some extra heart sounds like pericardial rub, fourth heart sound, S3 gallop, opening snap, and clicks, mid-systolic click and ejection click. And shown in the upper panels is non-adjusted scores, and in the bottom panels are adjusted scores that showed adjusted scores, meaning they did hear either the murmur or the sound correctly, but in addition, they heard something else that was not there. It was close to what was present, so the scores were adjusted. But across the board, you can see that the performance was not that good. All internal medicine residents, family practice residents, and medical students performed about the same, although they had different levels of training. Shown here now is, again, for the year of training, it was felt that maybe a couple of years of experience would improve things. But when they compared first-year residents in open bars to senior residents, third-year residents, for accuracy rates, it turns out that it didn't really make much difference, both for murmurs as well as for extra heart sounds. So the auscultatory skills, despite training, were somewhat limited. And on average, the internal medicine and family practice residents recognized 20% of all cardiac events that were correct. And the number of correct identifications did not improve with training and was not significantly higher than the number identified by medical students. This study was criticized in that, yes, we tested them for auscultation skills, but they did not have dedicated teaching, focused, concentrated teaching and auscultation skills. So in this particular study, they looked at the impact of teaching on cardiovascular examination skills. A total of 56 interns rotating on the cardiology service were randomly assigned to either an 8-session physical diagnosis course, that was the teaching group, and this was taught on a cardiology patient simulator, Harvey. And the other group, the control group, had no teaching. There was no supplemental teaching. Before and after teaching, interns were evaluated on 3 programmed simulations for mitral regurgitation, mitral stenosis, and aortic regurgitation, as well as they were tested on patient volunteers. And here are the data in terms of accurately detecting these particular murmurs, mitral insufficiency, mitral stenosis, and aortic insufficiency in the control and group, session 1 and session 2 at 2 different times without teaching. And then in the intervention group, session 1 was before teaching, and session 2 after they had their concentrated teaching. There was really no significant improvement or difference between the 2 groups, and very little improvement from session 1 to session 2 in the interventional group, where there was dedicated teaching. So overall diagnostic performance was poor. About 37 to 54% of the findings were correct, and it seemed like there was no significant improvement in the diagnostic skills following the teaching intervention. So this was somewhat disappointing, large study, and yet, the examination scores were poor. And there are many other studies that I don't have time to show, but we can conclude that cardiovascular physical examination is not easy and not very accurate across the board. I have to say, in my training, I've had some excellent teachers who were excellent at auscultation, and with exceptions, those types of individuals are rare. But I would say across the board, it's not an easy skill to acquire and not an easy skill to transmit and teach. Some of us do well, and most people are not very good at auscultation. So this in the background, and with the technological revolution that's been going on for the last several years, has led to new ways of examining patients. Some of you may know the Moore's Law. Gordon Moore was chief of Intel, and he predicted 50 years ago, or maybe even longer, that the number of transistors per square inch of integrated circuits were going to double every 2 years. And starting back in 1971, and now this goes beyond 2011, this doubling has continued, that there are more and more transistors for the same amount of space, and then more transistors for even smaller and smaller space, compacted into small devices. So this has resulted in development of laptops, laptop computers, cell phones, digital cameras, and all kinds of small devices where you have high computing power with lots of transistors, lots of processors in a small, compact device. And this is the technological revolution that has, in our field, led to emergence of point-of-care echocardiography. And shown here is a regular echo scanner. Echo scanner, even the lighter ones are a couple hundred pounds, 200 to 400 pounds. They're portable and they can be taken around for bedside exam and from patient to patient and from floor to floor. But still, even though it's portable, it's not very convenient. It is bulky and not always easily usable in different situations. Next to it, I have this small device in my hand. This is a GE pocket device, GE Pocket Echo. It weighs less than a pound and it's 6 by 3 inches. You can carry it in your pocket, and one is able to get fair amount of information from this device. Certainly not of the same quality and not the same range and not all of the functions, but enough to be able to make a diagnosis at the bedside, and that's very, very helpful. So about, I think maybe about 18 years ago, there was a company called Sonocyte, and they had come up with this small laptop device, ultrasound device, and this was early on, before the era of point-of-care echocardiography. And they came to us and they gave us this particular device on loan, and they wanted us to test it out and see how well it performed in a clinical setting. So we took the device and devised a study and took advantage of this and devised a study where we did echoes with this device. And these are some of the echoes from that particular device. You can see parasternal long axis views here with and without color, and equal 4-chamber view with color Doppler. So, I mean, they're reasonably good, and you can get a lot of information, and this is just quick at the bedside and immediate to help you with the clinical diagnosis. So, and some of the abnormalities shown here with similar device, shown here is this patient with left ventricular hypertrophy, pericardial effusion, and patient with mitral regurgitation with color Doppler, with using these handheld ultrasound devices. We published our findings in Clinical Cardiology back in 2003, and it was titled Rapid Screening of Cardiac Patients with a Miniaturized Handheld Ultrasound Imager, Comparisons with Physical Examination and Conventional Two-Dimensional Echocardiography. Our hypothesis was that use of handheld ultrasound device, Sonoheart, during inpatient rounds yields additional information to a carefully conducted physical examination, and the findings are comparable to those obtained by conventional two-dimensional echocardiography, which is the large, heavy-duty echo scanner. So we did studies in 100 consecutive patients on our cardiology service. All of them had rapid screening with the Sonoheart device during inpatient rounds. And the findings from Sonoheart were compared to the results from conventional 2D echo done with a regular scanner in a blinded fashion. And with physical examination that was done by a very senior, experienced, board-certified cardiologist. And he was, given a sheet of a paper to jot down his findings on each patient in terms of his physical findings. So I'm going to show you this data that's recorded in just binary fashion, plus or minus, absent or present. We didn't attempt to quantitate the severity, but just the presence or absence of findings using a regular echo scanner and comparing our Sonoheart small device with the regular scanner. And shown here are some of the things that we looked at: left ventricular hypertrophy and enlargement, comparing the large scanner with the Sonoheart small device. So you can see for left ventricular hypertrophy, enlargement, right ventricular enlargement, left atrial enlargement, and all of that, whether they're present or absent, Sonoheart and the small device and the large scanner agreed very well. We had good agreement and findings between the two devices. These were done independently and blindly, so with a good kappa value. Similarly, for left ventricular dysfunction and wall motion abnormality comparison, where here we estimated left ventricular ejection fraction qualitatively, just visual assessment. If it was good, we estimated at above 50%. If it was low, below 50%. And whether, either it was normal, above 50%, or low, under 50%. And then we scored it as either being present or absent, compared to Sonoheart with the 2D large scanner. Again, excellent agreement between the devices. And similar for wall motion abnormality, whether it was present or absent. Again, comparison between the images from the two devices with good kappa values for the findings. And similarly for pericardial effusion, we had good agreement between the two devices. On valvular lesions, for regurgitant valvular lesions, we looked at mitral regurgitation, aortic insufficiency, tricuspid regurgitation, and pulmonic insufficiency. Again, we scored for their presence or absence between the two devices, two types of echo devices, and the agreement was again excellent. We then asked our cardiologists to assess patients for the presence or absence of congestive heart failure. So this was based on physical examination. And they used things like the presence of S3 gallop, pulmonary valves, jugular venous pressure, edema, to diagnose whether or not patient had congestive heart failure. And that was compared to a visual assessment of left ventricular ejection fraction again, either above or below 50% by both devices, on images from both devices. So we try to compare the assessment of presence or absence of heart failure with presence or absence of LV dysfunction by the two devices. And shown here is, again, agreement. There was reasonable agreement. The kappa values are not very high, but you have to understand that this is comparing physical findings with a quantitative number. There may be patients with diastolic heart failure with normal ejection fraction, and there may be others that have advanced heart failure that's treated and may not have very many physical signs. So it's a difficult comparison, but still, they did separate the patients with heart failure by the findings on the two devices. And then we looked at 48 patients who were felt to be okay without any physical findings on cardiovascular examination. And in these 48 patients that had no cardiac findings by this experienced cardiologist, we found many lesions, many valvular abnormalities, regurgitant lesions like mitral regurgitation, aortic insufficiency, tricuspid regurgitation, pulmonic insufficiency. Again, we scored for their presence or absence, not for the severity. And in these patients without any findings on physical exam, many had regurgitant lesions that were undetected by physical examination. And their presence or absence compared very well between the two types of scanners. So our conclusions based on the study were that rapid screening with SonoHeart, that's the small device, provided accurate and additional information that would otherwise be undetected during physical examination. And introduction of this handheld echo into clinical practice may redefine the initial approach to patients with cardiovascular disease. And that was published in 2004, and the data was actually collected in 2002 and 2003. And this is well before the point-of-care echocardiography had been introduced or become popular, one of the earlier studies. Show you another study. This is from University of Oregon. Some kind of similar. They took 250 patients who had been referred for a standard echocardiogram, and they had physical examination, all of them, as well as echoes with the small device, handheld ultrasound, to detect cardiac abnormalities. So they used the standard echo as the gold standard and then compared physical examination, cardiovascular examination, and handheld ultrasound against that gold standard. So here are the data. In summary, you can see that handheld ultrasound performed way, way better than physical examination for LV function assessment, right ventricular function assessment, for valve disease, and all kinds of findings that handheld ultrasound, the percentage of correct diagnoses using the regular 2D echo as the gold standard was much higher than what was detected on physical examination, cardiovascular examination. So based on just these two studies I have shown you so far, and there are many now in the literature, we can say that point-of-care echocardiography is superior to cardiovascular examination, physical cardiovascular examination, and this includes auscultation, the stethoscope, that I showed you earlier, compared to the handheld echo. So that's another important point. So far, we have emphasized that physical examination is not very accurate, even in the best of hands, and that point-of-care echo, small device echoes are comparable in terms of information to the large scanners. And for sure, the information obtained is superior to what we get by simply examining the patient. Now, what is the impact on overall cost of care? This is very important here in the U.S., where the healthcare is very expensive, and I was always searched for ways to reduce cost of care. And so I'll show you some data about this cost analysis. So in this particular analysis, they took patients that came in. This is a model now, not an actual study, but it's just a cost analysis model, where they were triaged either with physical examination or with handheld ultrasound. So you can either have, let's say you have physical examination and you suspect something, and therefore you refer them for further assessment using these tests: transthoracic echo, perfusion scan, angiogram, MRI. Or if you feel the physical exam is normal and no further testing is needed, no further tests. Similarly, with handheld ultrasound, you again assess the patient and then decide whether or not they need all these additional tests. And the cost of each test is given. You can see that when we evaluated handheld ultrasound, the cost is slightly higher because the cost here figures in the cost of the device, and that's amortized over a 5-year period, the lifespan of the handheld device. And for physical examination, the cost physical exam was based on, let's say, the amount of time that it takes to do a physical examination, and the physician's salary. They then computed how much it cost to do that. And it turns out, using handheld ultrasound, we are much more discriminating in terms of who needs further testing versus just using physical examination. Using physical examination alone, you are likely to refer many more patients for further costly testing versus using the handheld ultrasound, where you can triage the patients much better and then refer patients that really need additional testing, and others that may not need the test can be discharged. So using this model, the average cost was about $644 for handheld ultrasound and $707 for physical examination, yielding a savings of about $63 per patient, which translates to a lot of money in a large number of patients. And if with the assumption additional tests would be needed, let's say a day or half a day in the hospital, then the cost of handheld ultrasound was about $1,200 versus $1,400 for physical examination, because with handheld ultrasound, you're able to discriminate better and only refer patients that actually need further assessment. For example, if you see LV dysfunction, you might want them to have a coronary angiogram or maybe a stress. Or if you see, let's say, a valve lesion, you may want them to have a transesophageal echo. And so that, would be decided based on the findings on handheld ultrasound. But if you did physical examination alone, you would refer many more patients for those kinds of tests, and the cost would go up. So using that model, and there are other models that show that if you use point-of-care echocardiography, it will actually reduce the cost of care, and one can have better triage and better decision-making in terms of who needs more expensive testing. And finally, the training in point-of-care echocardiography is very important, and we'll talk about that. I'll show you, there are many studies.
কারণ ধরেন গাড়ি তো লাগে আমাদের, ড্রাইভার আমাদের নিতে হবে। আমার রেগুলার ধরেন সপ্তাহে একদিন মাদারীপুর যাওয়া, আমাদের আসা, নারায়ণগঞ্জ যাওয়া, যদি আমরা সুস্থ থাকি তাহলে 3-4 দিন আমার রেগুলার যাতায়াত করতে হবে। মিউট করো গাড়ি ট্রিপ হলে বাসা গাড়ি চালাইতে হবে, গাড়িতে বসে থাকতে পারবেন না। সারাদিন আপনি চলে গেলে রাজীব সবাইকে মিউট করো না। রাজীব আপনিও বসে থাকবেন না, আমাদেরও গাড়ি বসা রাখা শুরু। রাজীব সবাইকে মিউট করো। করবেন কোথাও না কোথাও, নো ড্রাইভার নেই, কারো ডিস্টার্ব করে দুনিয়ার কথা বলছো, মানে আল্লাহ আটকে রাখবে না, সবারই সবকিছু চলবে।
হারুন প্লিজ মিউট। আপনার
যদি কোনো মানে একদম ফাইনাল যদি সিদ্ধান্ত নিয়ে থাকেন যে হ্যাঁ ফাইনাল, যে আমি চলে যাব, কোনো কথা নাই। রাজীব সবাইকে মিউট করো না রে ভাই।
Are we okay?
Yes, you go on, please.
Okay, you can hear me okay?
Yeah.
Okay. So now we come to training in point-of-care echocardiography. This is very important because the students and the physicians had to be properly trained to learn this technology well, so it can be applied properly. Otherwise, with not inadequate training or poor training, the technology can be misused and have very bad consequences. But I want to show you that the point-of-care echo can be taught very easily. In this particular study, 2 first-year medical students without any clinical experience received 18 hours of training in echocardiography over a period of 3 weeks. And this training included 4 hours of lecture and 14 hours of practical experience. A total of 61 patients with abnormal findings on the standard echo were examined by one of the 5 board-certified cardiologists, and the cardiac examination findings were documented. So they all were assessed clinically, and then the 2 first-year medical students were assigned after their training to use these handheld devices. So they all had the students used the handheld devices and performed echoes. And the students were not allowed to ask any questions of the patients. They had simply to go in there and acquire the images and make an assessment. And then the sensitivity, specificity, and accuracy of the students' findings and the diagnosis by the cardiologists, trained board-certified cardiologists, were analyzed using the standard echo as the gold standard. So I'll show you the data now. This is the diagnostic accuracy for medical students and cardiologists for accuracy of detecting these findings. So we have the medical students here in black bars and physicians in open bars. And you can see in every category: left ventricular enlargement, left ventricular dysfunction, hypertrophy, right ventricular enlargement, right atrial pressure. And in pulmonary hypertension, students were more accurate in diagnosing these abnormalities based on their echo. Now, the cardiologists here were depending on their examination skills. And it's not easy. I think these cardiologists performed as well as any good cardiologist. You're comparing physical exam diagnosis with hard findings on imaging. So the cardiologists here did very well, but it's the power of imaging, the actual images that, were much better in accuracy in terms of diagnosing these findings. And it was not easy for the cardiologists to come up, and they still did really well with just physical exam diagnosis. So what I'm saying is, it is not the cardiologist's fault. It's just that physical examination has its limitations under the best of circumstances. And this here shows the diagnostic accuracy for medical students and cardiologists. Again, we have students in black bars and the physicians in open bars, and you can see that for valvular lesions and systolic murmurs and diastolic murmurs, based on the handheld ultrasound and the findings there, the students were much more accurate. Again, remember, we're comparing against regular echo. The gold standard here is the regular full echo done by a big scanner. So, and that's how we calculate our sensitivity and specificity. So the students here did very well with their handheld echo, and the cardiologists did well with the examination, but that's the best they could, and certainly not as good as the handheld ultrasound. So you can imagine, if you have students trained in this technology and you're rounding with them on patients, even with the best skills, they are well ahead of you in terms of they use the ultrasound at the bedside in terms of if they're properly trained, detecting these findings. So again, the diagnostic accuracy of medical students using handheld ultrasound after a brief echo training to detect valve disease, left ventricular dysfunction, enlargement, and hypertrophy was superior to that of experienced cardiologists performing cardiac physical examinations. Now, you know, it's the important thing here is that when you use these devices, that the user has to be properly trained. If they're not properly trained, I can see that there's proliferation of these devices now, not only cardiologists, but now we have anesthesiologists, ER physicians, intensivists, and even a lot of general cardiologists using these. And so you see echo findings reported here and there. And sometimes if the training is not there, you can come up with wrong information, and that's worse than not having any information at all. So I think based on, and there are many other studies, I just showed you one here, that you can train students, residents, and even physicians who have not had training in echocardiography can be quickly trained to use echo at the point of care. And it can be very useful as an extension of your physical examination. We're not talking about replacing our standard echo with handheld echo. We are here so far talking about using handheld echo as an addition to your physical exam diagnosis, as an addition, as a part of your physical examination, not to replace the standard full echo. This is my group. I teach this point of care echo course at our medical school, and we teach it at the second year level. You know, we have 4-year medical school, and the second year students come and they want to learn point of care echo, and here one of the students is trying a small device on a volunteer just to get the technique down, and then they some of the schools have made it part of the curriculum. We're working on it, and some other schools actually purchase these small devices for their students, and right from first year, including Harvard, they are giving out these devices to their students to use after training. And it's intimidating for senior attendings and cardiologists to go on rounds with some of these students who are even residents, who are well trained and have a lot of information about patients that a simple cardiovascular examination cannot match. Again, one of the students examining this, and we have the full scanner standing by. As you know, the small device at this time has the standard 2D echo and color Doppler, but it does not have continuous wave Doppler, so it's limited in assessment of stenotic lesions at this time. But it will show you the valve morphology and, of course, the valve opening, and you still get a pretty good idea of the stenotic lesions. So that's kind of a summary of this field of point-of-care echocardiography. And, you know, whenever a new technology is introduced, there are always critics, and they will say, well, this is not going to work, and it's just another fad, and it's expensive, or all kinds of reasons, until they really find out the value of new technology and start using it. So this particular quote here, notwithstanding its value, I am extremely doubtful because its beneficial application requires much time and gives a good deal of trouble both to the patient and the practitioner, by John Forbes. It's not about point of care echo. It's not about the small device. It's about the stethoscope 200 years ago. That when stethoscope was introduced, one of the critics felt that it was too much trouble and it probably wasn't going to amount to much. But you can see how far stethoscope has come and has really become part of our persona. I mean, it's an identity for the physicians and cardiologists, and we still use it day in and day out. So I think with the technology rapidly improving, small devices are going to stick around. They will be better and better, and we'll be using them as part of our assessment. I think proper training and assessment is very important. I'm going to stop here, and then we can have questions and discussion. Thank you.
Thank you, sir. Thank you, sir. Thank you. It was a brilliant lecture, sir. In fact, the point of care echocardiography is not that much familiar in our country yet, so it will inspire many of our young colleagues and ourselves to adopt the technology. Sir, can you stop sharing your screen, sir?
Sure.
So we have got a number of experts in echocardiography and clinical cardiology in our panel. May I request my co-moderator, Dr. A.K.M. Monwarul, who is the Associate Professor of Cardiology in National Institute of Cardiovascular Disease. He's a very good clinical cardiologist as well as an echocardiographer. Dr. Monwarul, what is your opinion regarding this point of care echocardiography after this brilliant lecture?
It's really an amazing tool, I think, and also this is enjoyable by such a legendary person in echocardiography in the world. We are really happy. The device actually is very useful, and if it can be used in clinical practice, that there may be some practice-changing step in our daily practice. However, the problem is that this is expensive, and probably this may not be so easy to be introduced in our government sector. But still, we have to try our best. The one limitation so far I realized that there is lack of continuous wave Doppler modality in these handheld devices. Still, we can use this for the diagnosis and also for the management of cardiac problems as 2D M mode as well as the color Doppler are available with these devices. So let us try and hope for the best. I think in future we will also have these handheld devices probably in a cheaper version. Thank you, sir, for the brilliant lecture.
Thank you.
Dr. Monwarul.
Actually, how much is the cost, Professor Masood, today, handheld echo?
So for the GE device, I have one here. Let me show you. This is the General Electric GE
Yes,
device.
we can see you, sir.
Small transducer. Yes. And this one is about, the new model is about 10 or 11,000 dollars. But, you know, they work with medical schools and academic institutions and physicians. For example, if you buy them in bulk for a lot of physicians, they will give you a discounted rate. And you can work with at least we have been able to work with the company vendors to get them at better rates. But that's what they are about out in the market. I think the cost is coming down as more and more vendors are getting into it. So this is one device, and I've had this one for 6 years, still going. And I've done lots of patients with it. I take it with me when I'm on call because the echo technicians are not around. I find it very helpful in the emergency room. Somebody coming in with a cardiomegaly, huge heart, and one knows there's an effusion or just cardiomegaly, or you know, lots of different. Somebody has a murmur, so it comes handy. I'd also take it to the clinic. The only thing is, our time in assessing patients is limited, and sometimes it can take extra time and which is not always available. And at this time, it's not billable. We don't bill for it, so there's no revenue. It's just it's improved assessment. That's what we get out of it.
It is battery operated.
Yes, this is chargeable, and if I leave it on charge overnight, I get about 2 to 3 hours of use.
The machine is chargeable.
Yes.
It does not need extra battery to put in.
No, it's rechargeable.
That's good.
No, that's good. 10 or 11,000. 10 or 11,000.
Yes.
Was that it?
11,000 US dollar. So it is not
US dollars.
11,000 US dollar means
8 to 9 lakh taka Bangladesh.
9 lakh taka.
Can you please introduce yourself, Professor Afzal? Can you introduce yourself?
Professor Abdul Rahman, he's one of our experts of today's panel, and he's the Professor of Cardiology and also ex-director of NICVD, National Institute of Cardiovascular Disease. He is the former president of Bangladesh Society of Cardiovascular Intervention, and he is very much involved with our ISCU Bangladesh chapter. Sir, please go on.
No, thank you very much. But the thing is that definitely lecture is really good, great, and he also focused one of the important things that is small devices. And I will say that what Monwarul said that it is not possible in the government, but I am sure that it is more possible in the government sector. It is only 8 to 9 lakh taka. And by this mobile echo, you can go to the emergency, you can go to the cardiac surgery, you can go to the CCU. So that is very useful. I will say that it will be more useful than in a bigger machine. I will say that every institute should have at least one small devices for this. If I was now in the administration, then I will purchase this tomorrow. It is a small amount of money in the cost of, in the context of the government sector. It is not huge money.
Don't worry.
So I will say this is very useful. And for also the doctors who are practicing outside, that is also very useful. They can take it and they can go to the remote places and see the patient, and sometimes a problem we can see it. We shouldn't depend on any other bodies. I will say that it is better than the machine that is available in the remote places. The quality is not good, and that is mostly used by the ultrasonogram machine. Many of the places doing the ultrasonogram machine nowadays, they are doing that. So this is a very useful. So I will say that this is
just one point. For Bangladesh, I think this device is more important than the United States of America, because there are so many remote areas in Bangladesh where you cannot reach by the conventional echocardiography machine. So you can put the machine in your pocket and you can go to Vola or Hatia or any other offshore islands and they see the patient. Actually, this is very useful. It is very useful even in the clinical practice. In our clinical practice, when you are in hurry, you cannot see auscultate the patient very nicely. Then you just put the patient. I think it is more relevant to our situation in these situations than in the developed countries.
There was a question about why
continuous wave
continuous wave is not. The reason for that is continuous wave needs much higher energy, much higher power. And these devices right now are not geared for that kind of power. But I'm told.
Hello, sir. I'm at a meeting in Modha. I'm at a কথা বলতে পারবো না. Meeting.
Mute yourself. Moin bhai, please mute.
So they're working on it, and it should be available. That is the reason for the continuous wave. Let me show you one other model. This is called Butterfly. And it's a company, the name of the company is Butterfly. You can Google it, you can get information about it. And this particular transducer is much bigger, but it's used not only for cardiac ultrasound, but it has all applications, abdominal, gynecologic, pulmonary. So it has software that you can install for all types of examinations. And you can connect it with your, we have iPhone here. I guess you have something similar over there. So you can get images on your cell phone. You don't need any other screen or anything. You simply connect it to the iPhone. You get very high quality images. One other feature with this is it's much cheaper than our general elective device. in terms of just getting the probe. It's about $2,000. But the problem is you have to pay a subscription, annual subscription for the software, which is about $400 per year. So, but I'm told that the company is willing to work something out if an institution would like to have, let's say, more than 10 or 12 of these. They're willing to work out something in terms of subscription and all of that. So this is another device, Butterfly.
Thank you, sir. Dr. Mohammad Khaliquজ্জামান. Dr. Mohammad Khaliquজ্জামান is the Associate Professor of Cardiology, Dhaka Medical College. What is your opinion regarding this?
Thank you, Professor Masood Ahmed, for his brilliant presentation and the lecture and the contents of the lecture and the introduction of the new modalities in the field of the echocardiography. I think it will be very helpful in the evaluation of emergent situation rather than in chronic cases. In our country, we feel more, we want to give more emphasis on clinical examination. I think the introduction of this small device in the chamber practice or routine practice will make blunting of the performance of the students in the field of the clinical examination rather. As there is no option for Doppler interrogation and color Doppler interrogation, so there may be again confusion during the clinical examination and correlate is with the handheld ultrasound machine application. So there may be some confusion between the clinical examination with the findings of this handheld echocardiography machine. So I think it may make some confusion in the routine cases, but it will be very excellent. It will give excellent help in the evaluation of the emergent cases, particularly during ward round evaluation of the cardiac cases, rather than in chamber practice. I think so. So thank you, everybody, for patient hearing, and thank you, Professor Masood Ahmed, for his brilliant.
Thank you, Dr. Khaliquজ্জামান. In fact, we are trying to improve the clinical methods or clinical skill of our students. It is our continuous effort for graduation level and everywhere. So do you think using this handheld echocardiography will reduce their effort for clinical methods, or it will improve their clinical methods rather? Masood sir?
There is, again, here in US, there is a move to improve the clinical skills for students. But a large body of physicians feel that clinical skills are not easily teachable. They're not transmitted and not, you cannot really quantify. And this is one reason the boards, American boards of internal medicine and cardiovascular medicine, in their examinations are no longer testing for clinical skills. At one time, this was part of the practical exam, was part of the exam for boards, but they don't do it because they feel it's not objective and it really cannot be tested properly. So I don't know. I think, it's hard when we see patients these days, before you even get to auscultate the patient, you already have some type of scan that's been done. So imaging is all over the place. You have echoes, you have cardiac MR, CT scan. And so, the images are already there. And I think it's going to be increasingly difficult to compete with imaging. But certainly, I think skills, cardiovascular, teaching is very important at the same time. I don't think that should be ignored.
One thing is that in their curriculum, they started that echography in the first year of the medical school. That's right?
Yes, sir.
Masood?
Yes, sir.
Yes,
Second
yes.
year.
Many, not all schools. We're doing it from second year.
Remember that they are doing in the first year of the medical school. But
some schools are doing
yes.
it right from first year.
But here we are doing the maybe after completion of the MD cardiology or like that. So there is a conceptual difference between this and that. So that part is very important, and that part has to be addressed among our what we will say that the structure, those who are making the structure of the formulation of the courses. I think so. In most of the country, actually, even in neighboring countries, the ultrasonogram they introduced in the first year, And many of the clinical subjects they introduce in the first year. But our system is totally different. That is I'm not sure that UK, what UK is doing, I'm not sure. But in the other country of the country, even Singapore, Malaysia, Australia, America, everywhere, in the course of the first year and second year, some clinical context is included. That's I'm right, Professor Masood?
Yeah, yes. Increasingly, we're doing more.
Yes,
we're rotating students in clinics and teaching clinical medicine.
What is your comment, Professor Abdullah Shafi Majumder, in this?
No, you are right that the teaching of the ultrasound should be at the very beginning of the medical school. And this is the way we are working actually with the ISCU Bangladesh chapter or ISCU as a whole or any echocardiographic or imaging societies. They are coming up because as Professor Masood has brilliantly showed that the physical examination can show the accuracy around 50 to 60% in the physical examination, even after the proper teaching. So the methods of ultrasonic, not only the cardiac ultrasound, the lung scanning, the other things, the abdominal scanning, all these things, as Professor Masood showed, the second machine. That machine is the comprehensive machine for the general practitioners who can do all the imaging by a single machine. I think that will one day that will replace some of our methodology, I think.
No, that is one part is for the confirmation of diagnosis. Other part is that to introduce all the advanced modalities among our beginners also. That's also the thing is that they are introducing this. What are the modalities that can be applied in the field of the medical science for doing in the field of the special cardiology? That is also important.
What is the comment, Professor Wadud? He is the head of the Department of Cardiology of a medical college, the prime medical college, the principal medical college of Bangladesh. What is your comments? Do you think that our curriculum should have some division?
I think the point is that point of care echocardiography actually is a tool for initial diagnosis. For further confirmation, you always need the comprehensive echocardiography. And it adds as an add-on, like an stethoscope, to the clinical skill. And it depends upon any tool. The use of the tool depends upon how you want to use it. And if you want to use it to increase the diagnostic skill, the initial trial situation, how to differentiate which patient to go where, for that reason, this is a very valuable tool. And another point you have already mentioned, you can take it anywhere. Even where the electricity is not there, you can use it because it's a battery-driven tool. So, in that regard, and the cost, as Professor Abdul Rahman was saying, for government sector is actually not a factor. I think to make its use wide, we should train our young doctors more in this tool and make this available through the government sources. Then the cost will come down and really we'll be able to use it on our own in our personal practice as well.
Professor Tuhinok?
Yes.
Professor Tuhinok is the Professor of Echocardiography in the National Heart Foundation and Research Institute, Bangladesh. Ma'am, what is your opinion regarding this?
Thank you, Firoze. I'd like to congratulate Professor Masood Ahmed for his...
আপা একটু লাউড করতে হবে, শোনা যাচ্ছে না।
Okay, can you hear me now?
Louder, please. Louder, a bit louder.
Okay, I'd like to congratulate Professor Masood Ahmed for his brilliant presentation. Actually, point of care ultrasound is very much promising and it is considered as an extended stethoscope. So it is not reducing the clinical skill, but it is complementary to clinical skill. And considering the cost, I agree with Professor Afzalur and Professor Wadud that in every institute, especially in the cardiac institute, in the emergency department, we should have it. Because with the point of care ultrasound, we can reduce the number of cardiac admission. So it will be cost effective. So for government sector and for every cardiac institute in the emergency department, we should have the point of care ultrasound. to increase this use. And for remote practice, if the cardiologists, I think they can provide it by their self, and it will reduce the hassle of the remote patients, because to travel from outside to Dhaka for only one test is very troublesome. So use a point of care ultrasound will help in screening. Also, it will be help in mass screening for many study. So it is very much useful and very much promising. I want to make aware that we should procure it. 8 or 9 lakhs taka is not a very much expensive, especially for the government sector. They are procuring many expensive things. So, and in Japan, they are also using the point of care ultrasound, and echocardiography course are started from the 3rd year. So we should think about the starting of echocardiography course earlier in our medical students. Thank you, everyone.
Thank you. I think we are running late, at least in the place of Professor Masood Ahmed, because it is almost midnight. We want some quick comments from our panelists. Professor Mohammad, sir, your comment? Any comment regarding it?
Yes, this is a new concept in Bangladesh. There's a point of care. I think it is very much promising, not only in emergency department and in the remote area, but also in the busy practitioners who are a bit in confusion. They can confirm it in their table and in their chambers that it's such and such, and it is extended stethoscope. So I think it will be one day it will be very much popular in Bangladesh, not only in private sector or in government sector, but in cardiologist practice chambers. Thank you very much. Thank you, Masood, sir, for your nice and brilliant presentation. I'm really surprised that you have explained all the things in a very simple word. Thank you, sir.
Thank you, sir. I have got a query for Professor Masood, sir. Do you charge extra for this handheld echocardiography during your clinical round?
No. It's free. It's not.
You know, for here, you can only bill if you have documentation. So you have to actually record the images and have a report. The way we are using this technology at this time is just quick look, and we just document our findings in terms of just a note, but we don't write a report, and we don't really store the images. I think a day is going to come when we will do that, and at that point maybe we'll be able to charge and bill the patient. Not at this time.
Thank you, sir. We have got Professor Abdul Salam, ABM Abdul Salam, who is a pediatric cardiologist. Sir, what is your opinion? Because many of the neonates and neonatal ICU, we should use it, I think. Professor ABM Abdul Salam, are you with us? No. Professor Moinuddin Ahmed, you have got any comment?
Yes, I mean, I'm interested to. Oh, Salam sir, still mona hai.
You go with Professor Moinuddin Ahmed. You go with the comments. Your comments.
Okay, thank you. So I noticed two things. I would like to hear Professor Masood's comment also. I think there is two topics we're discussing about here. First is the clinical use of this device. Anywhere we go for initial screening as an add-on to the stethoscope as a clinical tool. But I think it has a very good teaching tool also for our students. We can use it as a teaching tool also. You tell them to auscultate first, find their write down their comments, and then use this device to tell them, to make them see whether they're right or not. So this is a very good new application. I think it may be a very good teaching tool also in the wards, in the students, clinical students. And as everyone has said, I agree very much with it. It's as a pocket tool for ultrasonic examination of the heart. It is a very good tool for clinicians everywhere, and it can be taken to remote places. It can be used anywhere in an emergency, as Professor Tuhin has said. So it has its application clinical, but in my view, it's also a very good teaching tool. I think it should be used in every institutions for teaching the students clinical skills. Thank you.
Dr. Khalid Mohsin, sir.
Yes, thank you.
Your comments, sir.
Thank you, Professor Masood. Actually, in USA and in Europe, the examinations are mainly performed by medical sonographers who doesn't have a idea about the clinical history and the clinical findings of the patient. So do you think that introduction of this technology is going to change the ultrasound practice of your country and Europe as well? Because it is different in Asia, because the physicians themselves are performing the examination. But in your country, the sonographers do it, then they forward the images, you review it and formulate a report. So the practice pattern is a bit different. So is it going to change this pattern?
Yeah, I think a lot of things are evolving. You know, even the standard echocardiography now, this year's American Society of Echo session, there was a lot of time devoted to artificial intelligence. That's going to take over a lot of data analysis and structured reporting based on the data that's available there. Many of these will be automated. So I think the practice of echocardiography is going to change over time. But, you know, I think to do a complete echocardiographic examination, which is what we do in our labs, it takes about 30 to 45 minutes to really do a good exam and do all the modalities, color Doppler, regular Doppler, now we have strain and contrast and, you know, all kinds of things. For a physician to get involved in that, it will be very difficult. It will be very expensive. And physicians just don't have time, at least in U.S., to do that. I think we will still have sonographers, technicians helping us. But this quick way of looking at things actually, in some ways, may increase the referrals for a full echo in many cases, not necessarily decrease the application of the, you know, the regular echocardiography. I don't know, it's complex, it's evolving. Did I answer your question? I don't know.
Yes, thank you. Thank you very much.
Sir, there is two terminology. One is point of care echocardiography, another is called focused echo. How do you define it?
So focused echo for us is if you have sometimes a certain issue, let's say we just want to look at left ventricular function, so we do a focused study for that. Or let's say there's a regurgitant lesion and we just want a focused study to quantitate that. So that's the general terminology, whereas point of care echo is a complete echo, but it's just a small device and done in that fashion. So there's a difference.
Thank you, sir. Professor ABM Abdul Salam, are you with us? ABM Abdul Salam, sir.
Yes,
Have you got any comment regarding? Yes, we can hear you.
Yeah, I have a small comment.
Okay.
Yeah, thank you very much, Professor Masood Ahmed from USA. Actually, what is happening? The world of imaging is changing very rapidly. Recent years, with the evolution of technology, we are finding there are a lot of devices coming in market for helping imaging modalities of different specialties, including cardiovascular imaging. And recently, after the pandemic of COVID-19, actually I was searching for a device for telemedicine use in my chamber, particularly digital stethoscope, because we are physically not present in front of patient, so they are mostly not satisfied during our clinical examination. So not only by the so I was searching some devices and I found one device that is known as from Butterfly company is known as digital core stethoscope. Like that, this ultrasound device, handheld ultrasound device, we can use in our chamber and we can practice it from remote. Although the 100% accuracy is not possible by this handheld echo machine, but you can assume or you have an idea of what is happening to the patient, what is the provisional diagnosis. So this is very useful, I think, and the cost is not so much high, and that digital stethoscope, I think I'm going to buy is only $100 US. So Professor Masood, you have a wonderful lecture or illuminating and eye-opening lecture. And we can use this modality of imaging instrument in our daily practice or in the hospital setup, particularly emergency situation like in emergency room or in the CCU, ICU, or you can use in your private practice, the remote place, or yeah. This is very important, particularly in this pandemic area where you want to avoid to be aerosolized to the patient, the attendant. So you can use this kind of Firoze, actually in Bangladesh we saw a lot of cardiologists affected with COVID-19 and some of them died. And most of them have the history of doing echocardiography clinical examination. So I think this is a very suitable fix to be discussed. As Masood showed, the validity of handheld ultrasound versus clinical examination versus the conventional cardiography machine.
একটু specific
Thank
question
you, Professor.
Thank you, sir.
Masood
Thank you.
sir.
Thank you, Professor Salam, sir.
Can you hear?
Yes, sir. Thank you, sir.
I
Thank
cannot
you very
hear you,
much for
sir.
your opinion, sir. Thank you. Any of the panelists, you have got any comment, queries for Professor Masood?
I think there is a problem of,
may I have a comment?
internet.
Yes, Dr. Nur Alam, please.
Yeah. Thank you. Thank you, Masood sir. I am Dr. Nur Alam from National Institute of Cardiovascular Disease. Thank you for your excellent presentation, sir. Actually, from today's lecture, I think that two aspects of Sir Masood sir lecture. First of one is, as he mentioned very nicely regarding the handheld echocardiography. In this COVID era, our new normal practice, in our new normal practice, we are not going for details or thorough examination of the patient, just to just to hear the history, and we can send the patient for echocardiography focus or focus echocardiography. And if we have the device that Masood sir shown us, that will be very helpful. This is one aspect. And second aspect is that, sir, this is the byproduct of, I would say, byproduct of sir lectures, that the evaluation of the examination system of our postgraduate students. Here two of our teachers are here. They can think, or actually there is the thought generating idea that not only the clinical skill, or I would say the traditional clinical skill that has been assessed by our teachers, that should be changed, or some change is needed. Just I want to draw attention or senior teachers for this.
Thank you.
So thank you again, Masood sir, for your nice presentation.
We had Professor Sajal Banerjee sir with us. Sir, are you with us now? Professor Sajal Banerjee sir? Probably no. Professor Abdul Wadud Chowdhury sir, you have anything more to add, or you make any other comment?
Everybody has enjoyed and expressed their comments about the whole thing. Let us hope we get the chance to get more accustomed to this new practice. And Professor Masood from FR will surely guide us how to acquire the expertise in the use of this new method. Thank you, sir, for your nice and
Professor Afzalur Rahman sir, you have got any more comments?
Thank you very much. I think so. This is a very important issue and important topics, and the important devices that are not used in our country, and definitely that will add values. And thank you for that. Thank you, Professor Masood, for taking trouble, and at the midnight he is giving the lecture. And definitely this chapter, the president of the ISCU Bangladesh and the team, I must congratulate them. And thank you all the faculties. Assalamu alaikum.
Thank
and
you
also all the participants, because I have seen that there's a lot of participants from different part of the country attending the meetings. We must appreciate that. Assalamu alaikum.
Thank you, sir. Thank you, everybody. Thank you, all the attendees. Next Friday, we are going to talk on mitral regurgitation, and Professor Abdullah Shafi Majumder sir will talk on mitral regurgitation next Friday. I think nobody will miss the session. And Dr. Monwarul, my co-moderator, anything
Yes,
to add?
yes. I think this modality will complement, not going to replace stethoscope. Clinical skill is must. As we know that we have so many stethoscopes, but they are not being used in a proper manner. And the skill, expected skill from the clinicians is not up to the mark, I think so. So we have to have our clinical skill adequately, number one, and then we have to complement our clinical findings by use of such devices. Certainly this will help, but this will not going to replace the traditional clinical skill, I think so. Thank you, sir.
Thank you, Dr. Monwarul. Now, may I request Professor Abdullah Shafi Majumder sir to conclude the session?
Yes, we have to conclude because I think I can say now good morning to Professor Masood Ahmed. Is it so? It is 12:30 at your end. So good morning now to everyone. And then usually we expect to go for a long time, but as it is a very strain on the part of Professor Masood Ahmed to remain with us, so we have to conclude here. And I think it is a eye-opening presentation or thought-provoking presentation, and it may help us for the introduction of this sort of machines in our country. And we will contact with you for how to train up our personnel. What is your module you undertake in your institution? We can seek your cooperation so that we can train some junior doctors also here, so that we can have these handheld machines in our country. Though Dr. Monwarul he's a very good clinician, Dr. Monwarul Islam. So he defends the clinical examination more and more. But whatever, because I'm more clinician, inclined to the more clinical examination for my last experiences. But when the new technology comes, we have to accept it. We have to accept it, and we have to give way to the new technologies. So as the Professor Masood said, how the stethoscope was also challenged in the early days. So I hope that this machine will be helpful for us. As I already mentioned, that it will be helpful for us to go to the remote areas with this machine and to have the physical examination with this. It is a sort of physical examination with this machine. As Professor Tuhin has rightly pointed out one thing, it is also helpful in the mass screening, particularly in our country for the rheumatic heart disease in our mass people. We can use this machine for the mass screening of the rheumatic heart disease, presence or absence of the rheumatic heart disease in the children. So it is a very good machine. It will be a very good machine. I also talked to you some years back how to procure this machine, but I did not continue my interest. But this time my interest has again ignited. So I hope that some of my colleagues also will be interested to have this machine, and we'll talk with GE for having this machine available in our country. With these words, and again my sincerest thanks and the gratitude to Professor Masood Ahmed to join with us and to give us a so valuable presentation. And also I must thank our faculty, our panel of experts, Professor Afzal and Professor Wadud, and other faculty, Professor Tuhin, Professor Shahabuddin, all they join us, Professor Shazul Banerjee, who is also the Dean. I think he will also have some thoughts on the procuring the machine. And I must have my thanks to Mexico Pharmaceutical for supporting this program, particularly Dr. Jamshidul Hassan, who is with us for all the time. With these words, and again, with thanks to everyone, and with my gratitude to Professor Masood Ahmed, and we hope that he will be with us in the future also. And with these words, I conclude this webinar. Thank you very much.
Thank you. Thank you.
Thank you, Professor Masood Ahmed.
Sir.
Thank you. And good night.
Good night, sir.
It is good morning, I think, to you.
Good night.
See you.
See you, sir.
Thank you. See you.